Now, ketamine in acute pain, yes, by Dr. Khalid Khalaiwi. He's head of Department of Emergency Medicine in Al Habib in Dubai. He's American certified emergency physician, and he will talk about yes, say yes for ketamine in acute pain. Please welcoming Dr. Khalid Khalaiwi, please.
Assalamu alaikum, thank you. It's Khalid Khalaiwi. Khalaiwi is in Jeddah. We're like different families,
Yeah,
but it's okay.
Okay.
Hello, thank you for the invitation. When I got the email for the invitation, I saw the title and I was thinking, I gotta be on the yes side. I have to be on the ketamine yes side. And then learning through the process and going through the medical literature, I'm now convinced, and I hope you're gonna end up with the same conclusion. So ketamine is kin, and then if I want to convince you that you will introduce ketamine in your practice, I have to go through the process, the principles of change in medicine, which is first I have to convince you that the intervention is safe, and then I have to tell you that it's effective, and then I have to tell you why should you include it in your practice. Would you agree with me if I was able to achieve these, you would change your practice? Okay. So we love ketamine. Who does not use ketamine in their practice? Zero ketamine. Okay. This is the menu list of the stuff we use for ketamine. We use it for procedural sedation, for RSI. If you have somebody who's agitated, you want to buy some time to oxygenate them before intubation, you use ketamine. If you have somebody with asthma, it has some bronchodilatory effects, use ketamine. We can use it for to calm down very agitated patients in the ER, and we can use it for refractory epilepticus. I saw one comment on the internet by one of the ED docs, we should include ketamine in our normal saline bags. It's that good. So, as was talked about already, we have a problem with pain control in the ER. This study highlights it. 43% of patients who come to the ER do not get adequate pain control. And if the vast majority of patients in the ER have pain, that translates one thing to me. We are not doing a good job. And if there was something we can do to improve that, we should introduce it. The door to pain control, I mean, the extent of the problem is some quality measures have introduced this target measure, door to pain control, as a quality metric for ETs. And as an administrator or as a practicing doctor, you need to think about it and focus on it as one of the care measures that you want to assess yourself with. Low-dose ketamine was introduced by anesthesia, surgery, and palliative care. We know about the problems of opioid use. And for the past 15 years, more and more studies are popping up that show ketamine is an alternative and can be used for pain control exclusively. Now, the dose is different. Low-dose ketamine is defined as 0.1 to 0.3. Some studies go to 0.5. The other terminology for low-dose ketamine is non-dissociative dose, because the effect it goes up with the dose. If you go with the 0.1 to 0.3 milligram per kg, you end up with pain control. If you go to the standard dissociative dose, the 1 to 3 milligram per kg, then you get into a different treatment. So focus on the dose. The dose here is, we're talking about 0.1 to 0.3. And in most studies, it was studied as a slow IV infusion, 3 to 5 minutes is how we use ketamine. If you want to think about it other ways, if you have an average adult, you would give him 20 milligrams IV. All right, so we're going through question number 1. Define if it's safe. Ahan et al. In 2015 had looked at 530 cases, retrospective review of use of ketamine for pain control exclusively. And they looked at if there was any cases of cardiac arrest, apnea, hypoxemia, laryngospasm, MSS, psychomotor agitation, or frank psychosis. This is within the ED population. Does it sound to be a good question? All right, let's see the results. So among those patients, 33% received it for abdominal pain, 12% for back pain, 5% for chest pain, rest for musculoskeletal pains. It sounds like this is an average ED population. Side effects reported in 30 patients. 30 patients out of 530, which is about 6%. 7 of them had transient hypoxemia. All of those transient hypoxemia patients were corrected with pneumosaline with nasal cannula only. And only one hypoxic event was a problem. It was a COPDer that came in a crisis at triage, was already hypoxic, and it was difficult to handle, but eventually managed. But that was only one. 3.5 patients had transient psychosis. This is what they said. It's about the average comments that we hear from people with ketamine. Remember that this is transient. This is what they say at the ED, and by the time they get home, they're going to be fine. Only one patient had a major freakout. It was an old man, had cancer, and it was managed with lorazepam. So even that problem is manageable. 1% vomiting rate. Think about what would be the vomiting rate if these total 530 patients received morphine. None changed disposition and none caused permanent harm. So what do you think? Is it safe? Still? Okay. All right, let's move on to the next question. Low-dose ketamine or morphine versus morphine for acute pain. This is a randomized controlled trial, 2015. It was a double-blinded tertiary trauma center, and including adult population. We're talking the same definition of low-dose ketamine or IV morphine, 0.1 milligram per kg, with the primary outcome of maximum change in Neuromark rating scale for pain, the standard pain assessment, standard of care, standard deviation, and the power is about the average for what you would see for the medical literature journals. And these are the results. They had 45 patients. Time to maximum reduction in numeric rating scale for pain scores was 5 minutes for low-dose ketamine, 100 minutes for morphine. This is the major highlight of the study. You give the patient ketamine, the average, in 5 minutes their pain will be controlled, or pain will be a little bit better as compared to the morphine. They looked at the vital signs and adverse events, and provider and nurse satisfaction score were all similar between both groups. So again, I'm going to wrap up. This is the one thing I'd like you to remember from this slide. Look at ketamine. Think about your patient who's crying in pain. They come to your ED seeking help. In 5 minutes, you can control the pain. Yes, granted, maybe in about an hour or 2 hours, it's going to be comparable, but the pain control is going to be much faster. More studies looking at the same population, and again, coming to the same conclusion. One thing I want to highlight. I'm very sorry. 1 minute. Look at ketamine control of pain compared to morphine. This is the pain change in 30 minutes, and look at the performance of ketamine or morphine. So question number 2, is it effective? All right, these are the side effects. If you can tell, it's almost comparable. Headache or drowsiness, 0 in the ketamine group. More studies showing the same thing. So I hope with this I wrap up, and I could convince you that it's safe, as effective as standard of care. We know ketamine has superior hemodynamic stability and respiratory stability. One last thing. If you have a patient who comes to your ED in severe abdominal pain and tells you, you know, doc, 2 years ago I was in another hospital and they gave me morphine and I ended up in ICU. Would you give them ketamine? I'll leave that for you. Thank you.